Hello, my name is Warren Mansell. I'm a reader in clinical psychology at University of Manchester. This is my talk for the EABCT conference 2021. I've titled it All Roads Lead to Rome because of our experience in showing a core process underpinning the many different cognitive and behavioural processes that we've found to maintain psychological distress. The subtitle of this talk I will elaborate as I go along. So, why is it useful to identify a core transdiagnostic process? It's more parsimonious. This is Occam's razor. This is the way that we make scientific theory no more complex than it needs to be, by not replicating terminology and constructs that could be condensed into a single factor. It therefore provides, in turn, tighter theory practice links for providing therapy, simpler interventions, that are then more efficient to deliver and more efficient to train. I'm going to share with you 3 of the studies that we've conducted to identify a core process. They include 5 samples between them. First study back in 2013, led by Timothy Bird, recruited a student sample and a sample in the community with a chronic physical illness. And in both of those communities, we administered the experiential avoidance scale, a measure of worry and a measure of thought suppression, deliberately choosing processes that were on the surface of it different psychological components. And Tim conducted a structural equation model to contrast a model that combined them into a single factor by extracting their common variance with one that kept the 3 different scales intact, and saw in the physical illness sample whether that could predict anxiety and depression and distress, and similarly in the student sample, but this was done to predict prospectively over time increases in those symptoms. And in both of those groups, the single factor predicted distress as well as combining them separately. So the single factor was the more parsimonious solution. In a study by Trishna Patel with myself and David Veal, Trishna recruited a large mixed clinical sample from a very wide set of services, and also a community and a student sample, and developed a scale where each item was a different process from the large-scale review of cognitive behavioural processes that I conducted with colleagues in 2004, and then subjected that measure to a parallel analysis, quite a stringent way of deciding the number of factors to extract from a data set. And she found that 12 of those items correlated over 0.4 with a single factor, and the other factors correlated with very little of a variance. That single factor was elevated in the clinical group compared to the community group, and the clinical groups did not differ from one another on that factor, again pointing to a single core transdiagnostic process. And then in 2017 I worked with Peter McAvoy in a sample of over 300 patients with anxiety and depression, whom Peter had asked to complete a wide range of different cognitive behavioural and affect regulation measures. And for the first time we decided to subject that to a factor analysis. And again, a single factor solution was the most efficient representation of the data. Just to check, we also extracted later factors, which accounted for much less variance and didn't correlate with symptoms with anxiety and depression. Only the single first factor did. So across all those different groups, across those studies, we're pointing to a core process. And it's not just our group. There was a large meta-analysis of emotion regulation that found one factor, and a large study of onset, maintenance and relapse of anxiety disorders that again found a single latent factor predicted these, even though there was different data from scales of experiential avoidance, anxiety sensitivity, rumination and worry. It was that latent factor extracted that was predicting the symptoms. So this begs the question of what that core process could be. and our work on this has come from a different direction, partly by listening to patients' accounts of their mental health difficulties and their recovery, where we find that mental health problems are characterised by the experience of loss of control and hitting rock bottom, and the recovery is that gradual regaining control of one's life. And we find that theme both within the qualitative but also in the wider psychological literature. I also came across perceptual control theory when I wanted to try and see how to connect up the behavioural low-level processes with the higher order cognitive processes, and that's when I saw that this way of understanding that link seemed to be most parsimonious, if you like. So what is control, according to this theory? Control is about making your experiences the way you want them to be. It's like getting a just right state. So control happens when we engage in any action, any behaviour, even varying what we do on the fly, to make our experiences, our perception, be the way that we want it to be. So we might have a goal to control how tightly we grip something, to control and experience the satiation when we drink something. We might want our anxiety levels to be in a certain range, or our excitement levels to be in a certain range. We might even have a sense of how honest we're being while we're talking, or our tone of voice that we're trying to keep in the right range. Now obviously we're not consciously trying to control all of these things. So the idea in PCT is that we organise all the things that we're controlling in a hierarchy, with the global abstract goals sitting at the top. Sometimes these are outside our awareness, our values and our principles, and the very immediate things we're controlling in the moment, like our positioning and our exact words, which again we're doing quite automatically. Our awareness tends to sit in the middle of this hierarchy. But what is it that undermines control? There can be physical injury, there can be trauma, but according to PCT, the most subtle factor that can undermine control is goal conflict. It's about wanting two incompatible outcomes. And this can be manifested in very different ways for different people. For some people it might be to be fiercely independent, but also needing to be dependent on others. It might be to report one's memories of trauma to get justice in a court case, but also be terrified of having them back in your mind because you feel distressed and you're going mad. Or even in phobias, it might be about facing your fear, getting closer because you want to be a strong person, but also wanting to run away just to feel safe. And so the idea is that we all have these conflicting goals in life. We normally bring our awareness to them and start to resolve them ourselves. And that's through exploring them, talking them through, considering them, letting our minds kind of fill with perspectives on what we want and how we want it. So the idea is that we go to that high level when we try and weigh those things up. It requires a sustained awareness and an exploration of what this decision is. And according to PCT, there's a learning algorithm called Reorganisation, which is a trial and error change process. It's spontaneous. Thoughts and solutions pop into our head, often at unpredictable times, and that seemed to be the result of reorganisation. But we can control the likelihood it'll happen by sustaining our attention, sustaining our awareness on our thoughts and feelings about a problem. One way of pointing to how this might try and understand the transdiagnostic processes is the consideration of flexibility versus rigidity. And I know cognitive flexibility is one of the themes of our symposium today. According to PCT, cognitive flexibility is about being aware of the potential conflict, the potential ways that doing one thing can get in the way of another thing, be counterproductive if you like. Whereas when we're cognitively rigid, our awareness is stuck on that strategy or that situation that we're managing, and we're not reflecting and considering the wider scale context and the wider scale goals. And in a review study that Lydia Morris carried out with me, she found that some key transdiagnostic processes such as rumination and perfectionism are associated with greater cognitive rigidity across disorders, which may indicate that it's not the process itself that's the problem, but the fact that it's been applied in this rigid way without awareness of the wider impact that it has. We also did studies trying to measure goal conflict awareness. It's quite hard because we're measuring something outside awareness. But studies that have done this in the past, and Rebecca Kelly reviewed this, showed that when goal conflict is measured implicitly, its relationship with distress is higher, indicating it's something about it being held outside awareness. And conversely, we've done 2 studies that show when people are encouraged to describe and explore their problems using text, when that text is coded for the presence of goal conflict terms, it's that degree of goal conflict awareness that mediates the effect of the intervention in alleviating distress. So that's some encouraging evidence that this could be our core process of psychological intervention. Method of Levels is our one-to-one therapy that provides that intervention. It has a long history going back to the 1950s, but it was formalised as a mental health intervention by Tim Carey in the 1990s, working with Bill Powers, who developed the theory. It's a therapy that's focused directly on this core process, and it's very simple in its application. And the therapist only needs to focus on 2 goals, but focus on those wholeheartedly. To ask the client about the problem and to ask about disruptions. Disruptions are a sign of what we call background thoughts. These are verbal thoughts or feelings or images that are in your background of your awareness while you're saying something. And sometimes when you're talking to someone who's thinking in that way, you notice that their eyes might flit to the corner, or they might smile, or they might pause, or they might emphasise a certain word. Asking about disruption is asking about that, saying, what's going on there? Are you noticing something else? What made you smile just then, etc. And so the idea is that we're both focusing on the foreground of consciousness as the person's verbalising about the problem and exploring it and expanding on that in a really curious way. But at the same time, we're also interested in the fringe consciousness, the background, helping the person of their own control decide to bring some of that to explore further, going further than they would have done if they hadn't been asked that question. And the therapist remains attentive, curious, and even playful in how they're engaging and asking things of the client. And we find that when we do Method Levels and we compared it to other therapies, it's very different from other therapies in its characteristics because it doesn't include any other specific techniques or strategies. The therapist is talking for far less amount of time than the client in Method Levels compared to other therapies, even though the therapist is chipping in every so often with their question in this iterative way. Ideally in Method Levels, the clients control their scheduling, the duration of an appointment, what problem to discuss, and so it's very handy for a drop-in session either in the community or in inpatient wards, and the clients can choose other aspects like the therapist and the frequency, etc. Now, I'm not going to go into detail about the research on Method Levels because we've been doing it for a number of years. So I've got this slide here for 3 key review papers which I think would be good sources of the research literature, so you can come back to those. But just taken as an overview, we've done a lot of qualitative studies listening to people who've experienced Method Levels in high schools, primary care, in the community, but also in early psychosis and psychiatric inpatient wards. Very different groups, but they all describe the benefits of being in control and of talking freely and noticing new perspectives when they're given this approach. There are pragmatic open trials in primary and secondary care with very mixed diagnoses, very little screening out of patients, with large within-patient effect sizes, pre and post, and some indication that Method Levels does this in a smaller number of sessions. However, there's no large-scale randomised controlled trials to date. And then we've got another body of research looking at mechanism. We've got an independent rater scale trying to tap into indications of this shift in awareness that we're trying to tap into, and also studies, for example, where clients review videos of their own therapy and every 2 minutes rate it for certain aspects that we predict from the model. So for example, their control over the session relates very closely to their sense of helpfulness on this minute by minute level. But we also recognise that method of levels is a one-to-one therapy. There's limits in how many therapists you can train and deliver on a one-to-one level. So we do also have an automated digital artificial agent that tries to emulate method of levels by scanning text as a person types about a problem and helping them to explore it and scrutinise it in more depth and detail. It's a bit like a electronically scaffolded expressive writing. We also have some group interventions. Take Control course has been done in person and online. That's a 6-week course that we've got a published manual for, and a trial showing that it's over 6 months it's non-inferior to one-to-one low intensity psychological therapy. And then we've got the 4 Ds of dealing with distress, and that's to try and bring these approaches into the workplace environment, because we've been contacted by teachers, social workers, mental health practitioners who want something for themselves, especially during the COVID crisis. And 4Ds is a very experiential, interactive 90-minute session to help crystallise both short versus long-term ways of regaining control. But ultimately, we're moving into an approach where we really want to try and embed this way of engaging in what we're calling the discovery mode into the community. And so discovery talk is a way of empowering people who are not necessarily mental health professionals to have a conversation with another person that follows the same principles and method of levels, tapping into the same core mechanism, helping the other person get into that discovery, reflective, problem-oriented mode. The training for this is self-generated and interactive rather than kind of material heavy. So you bring out, you understand what knowledge base the person has in their own jobs, and you help them use that by metaphor to understand control and conflict, and then you bring out experiences they've had supporting others through active listening and curious questioning or other techniques, and help them focus it in a direction towards this discovery talk way of supporting each other. The idea of discovery talk then is that you pass that on through communities, and so it has a much greater scalability. So in summary, I didn't cover the evidence that cognitive behavioural processes are transdiagnostic. That was established in 2004, and since then evidence has only corroborated that. I have shared evidence with you that there's a single core transdiagnostic process. Again, very strong evidence, I think, even from the 7 or 8 studies that I've reviewed here. There are others, but the question of what that process is more emergent, and there'll be multiple opinions on this, but our view is that what maintains distress in the long term is a restricted awareness of goal conflict leading to loss of control, and so therefore the way we help people relieve distress is to facilitate that awareness in opportunities and situations that the client can make choices around the topic of problems, the pace, etc., etc. And so that's why we have method levels therapy, but it's also why we're developing these multimodal transdiagnostic interventions, and why it may be that something more community-oriented, such as discovery talk, is the way forward. Lastly, I just want to talk to you about the Transdiagnostic Approaches to Mental Health conference. The last one of these was in 2018 that Tim Dalgleish put on in University of Cambridge. We've got round to doing another one 3 years later, online. We've got a 2-day programme of keynotes, presentations and posters that capture the whole transdiagnostic spectrum across disciplines and across approaches. It includes psychiatry, social cultural factors, A diagnosis, network approaches, neurotrauma. It's a very broad capturing, but they all share in common the transdiagnostic orientation. So I do hope that some of you will be able to attend that too. So thanks to Magnus and Paul and John for the opportunity today, and I look forward to the questions.